started. I'm hearing some typing and things in the background, so please do mute your lines during the presentations. You can chat questions during the presentations to Erica Palmer. So cue those up for us. And we'll also take questions after each presentation, so you can unmute your line and ask questions of the presenters. And as Mary said, if we lose connectivity, please stand by for further instructions from us via email. I want to just quickly say, because I'm on a high today, yesterday I was at the San Diego Integration Summit that Marty and his team convened in partnership with their county partners and several provider partners. And I just wanted, huge shout out, yay! One of the messages was celebrate success, and so I want to be sure that we do that in our learning community as well. And a couple of just takeaways I wanted to share that I think have relevance for all of the work that you're doing, that I'm struck by spending the day with this 300 people, which is incredible. One is the power of relationships between and among providers to really advance integration at the system level. So providers talked a lot about getting addiction services, mental health, county, primary care, really in a room together, and also doing site visits to each other's facilities to really strengthen those relationships and partnerships and to advance integration that way. The second takeaway I had was around measurement. It's about creating, picking measures and really sticking to them. And also figuring out how we can do lighter and more effective measurement. So I think that's something, a growing issue of importance for us and one we can work on together. The third was looking at some interesting workforce issues, looking at the role of the care manager, behavioral health professional in the team, a lot of talk about team-based care, the use of psychiatric nurse practitioners. So I think there's some really creative stuff to think about on the workforce front. And I'll send you guys a link via WebEx to the Integration Institute site, but a really terrific presentation I wanted to highlight from one of their keynote speakers, Lori Rainey. And there's a lot of detail in her slides on the issues that I just mentioned, and I think a lot of references too to studies that are coming out and some really interesting stuff around culture change to advance integration. So, and also linked to that, just I could close here, I wanted to give a big thank you and a shout out to Marty and his team because it was a really, really great day. And so, thinking about hosting a similar convening, I encourage you too to reach out to them and look at their website about the kinds of agenda items and the workshops that they had, the speakers they brought in, because it was really, I think, a huge success.
It is available to paid consultants.
And the second thing I want to mention is I'm so excited. We have Michelle Soper from the Center for Healthcare Strategies on the phone, and Mary will introduce her, but I wanted to just reiterate that one of the goals for us in this work is to really make an intentional connection between the work that you all are doing on the ground in counties and the conversations that are happening at the state level, really in real time. Both, and Michelle will say more about this, but we want to leverage your experience on the ground to shape those initiatives, and we also want to make sure that you're aware of what's happening at the state level and how it could impact your work, both positively and negatively potentially. So I think, just urge you to follow and what's going on at the state level, and Michelle will talk more about that, but also just encourage you all to weigh in. You have experience in this field that, is so critical in the policy conversation. And so we really want to make sure that feedback loop created and is really intentional and we cultivate in our work in this learning community. Stop there and turn it to Mary.
mute. I followed your instructions so well, Rachel. I forgot to unmute myself. Well, thank you, Rachel, and congratulations, Marty, and the San Diego team on an excellent. Sounds like an excellent day. I know that we've been working. I've had the privilege to work with you all for many years now, and it is really, really remarkable what you have accomplished in San Diego. So hopefully it will be infectious, and we'll be able to have that spread throughout the state. I just want to welcome Michelle, and I'll let her walk you through her slides and let her talk to you a little bit about what the Center for Healthcare Strategies does. Early in my pursuits around integration and the early work that I was doing with the Integrated Behavioral Health Project, the Center for Healthcare Strategies became a real ally and thought partner for me in helping me sort of think through how we could elevate best practices in California and to really learn what was going on around the country. So I've always thought of them as a real colleague in this work, and I'm really excited that we have an opportunity to work with them here in this initiative. And as Rachel said, their work is so powerful and so good, partly because they are able to get such great input from people working in the field. So hopefully what we'd like to do is have Michelle give you a little bit of an overview today about some of the projects that they're engaged in that have roots in California and that intersect in some way with behavioral health in California, so that you can get familiar with them today. And then next webinar, which is scheduled for January 21st, we will set aside some time for you all to have a more focused and deeper conversation with Michelle and her colleague Allison Hamblin, who couldn't be on the phone today, from the Center for Healthcare Strategies. And as Rachel said, give your input into some of the key projects that they're working on that will have an impact in your work in California. So we will be sending out you'll see in the post-webinar Survey Monkey that Erica will be sending you right after the call today, that we're asking you to give us some feedback on the projects that she'll be talking about briefly now, the ones that you really want to hear more about. So we'll work with her and Allison and you all over the next month to tailor that presentation for our webinar in January. So let me stop there and invite you, Michelle, to walk us through your slides, and welcome and thank you for joining us. And maybe advance the slides, Carolina.
Thank you so much, Mary. Thanks for that, and Rachel for that wonderful introduction. I also wanted to make note of my colleague Allison, who couldn't be on the call today. Something came up the last minute. She's really the driving force, CHCS, for all of our complex work on complex populations, behavioral health particularly. So she's just a real asset, to all of you and to me at CHCS. So just to make note of that. So I just have two really brief slides. The first one, which I think is maybe the next one, maybe one more. Yeah, there we go. Thank you. This is just a really quick overview about the Center for Healthcare Strategies. We are a nonprofit, nonpartisan health policy resource center. We've been around for about 20 years. And we partner with states around the country on improving healthcare services for low-income populations, many with a focus on people with chronic health needs. So state Medicaid agencies form the biggest part of our business, but we also work with the federal government and health plans and providers as well. And, just real quick to sort of summarize all of the information on the slide, what we do and what our priorities are, is the president of our company is quote him in his key motto, which implementation is where policy falls down. So that's really drives most of our work, is how we can act as a convener and keep our finger on the pulse on what's happening in states, to really share best practices and identify strategies and approaches that put good policy into place to help programs succeed. So that's really the underlying theme of our work. So the next slide shows just a brief snapshot of our projects that I think might be of most interest to all of you on the phone. So I'll just walk through these really fast. And again, happy to answer any questions or in the future that you have questions on. So the first project we're working on, and I actually had a conversation with Rachel about this today, so this is very timely, is we're helping the state of California some work on thinking about how to the renewal for their existing 1115 to reform waiver. It will be up for renewal in October of 2015. So we are working as part of a team of technical assistance providers that, and Blue Shield of California is our funder, that helps support the efforts of the state and several work groups that they've put together. So there's a few work groups to help think about what key policy initiatives should be in this waiver, and the one that I'm most closely involved in is the Plan to Provider Incentives Expert Stakeholder Work Group. So basically what this is a team of people from the state and health plans and providers and then key organizations represent various parts of the healthcare system in California are looking at developing incentive structures between the state and the plans and providers. Any of these proposals that we're talking through now in these public work group meetings are going to be opportunities to advance coordination and integration between managed care plans and behavioral health providers in the county. So there's a lot of idea right now about how to increase care, increase coordination, potentially co-location, and how to have more shared accountability across the different facets of the system. Other related work groups that we're involved in are thinking housing issues, and then there's also Disrupt 2.0 are thinking about ways to improve the current program. Also, and this is something that Allison is working closely on, working with both and the national effort and then in California to work on the Medicaid Health Home State Plan option. So this is an option that was authorized under Section 2703 of the Affordable Care Act. Many of you are probably familiar with this because California is pursuing this item. And this basically allows states to create health homes that coordinate the full range of medical, behavioral health, and long-term services and supports needed by people with chronic conditions. So CCS is the Health Home Information Resource Center, which is funded by CMS, and the one-on-one technical assistance resource for states that are pursuing these Medicaid options. We're also working with California directly to help think through design and then later implementation of Medicaid Health Home option, which will also along with a broader initiative under the CalSIM initiative right now to develop health homes for people with complex needs across payers. So that's something that I think will be of potential great interest to some of you. I've also done a lot of work with just behavioral health, physical health integration across different states. A lot of this work is mostly ad hoc or one-off projects or efforts. We're working well with California. And I should also say that all of these projects I'm here too, besides being related to behavioral health, also involve California in some way, shape, or form. Done some work with New York, Texas, and Pennsylvania recently, and there are states that are all thinking about strategies to either fully integrate behavioral health into the physical health care or just better opportunities to coordinate care across systems. So we've provided a lot of technical assistance in helping states design and implement integrated managed care delivery systems, particularly what challenges to anticipate and what are key considerations for success. So I would say that a lot of the work in this area has been at the systems level, so helping states think through how to work with plans and plans how to work with providers. So I think this project is so interesting for us to hear more about ideas and challenges and opportunities at the delivery system level. And actually, and this is what I work on primarily, is integrating care for Medicare and Medicaid enrollees. So working on projects that help improve care for dual eligibles or Medicare and Medicaid enrollees. So we've done a lot of work with states. We are a contractor for the Medicare and Medicaid Coordination Office at CMS and support CMS and states' efforts to advance either financial alignment demonstrations. So Connect is included in that, and other states that are pursuing these demonstrations. And then we also have some foundation funding to states, aside from our work with our federal partners, help states that are pursuing either demonstrations or other models that better integrate Medicare and Medicaid. And this is none of the projects are specifically tied to behavioral health, but behavioral health is an important element for all of these, just given the prevalence of these conditions in the Medicare, Medicaid, enrollee population. I'd say in terms of our foundation-funded projects, we have a project with the SCAN Foundation right now. Has a lot of different areas, but one thing of particular note is that we are working with SCAN to plan a series of meetings in California to support DHCS's provider engagement efforts for CalMediConnect. So these will be regional meetings that will bring together health plans and plan delegates and other providers to have some conversations about care integration and operational issues. We did these in 2014, one in August, focused on behavioral health, was in Long Beach, and that was very successful. So we're hoping these will help provide some information and tools for providers to learn more about CalMediConnect and how they can work with it. So that was, I wanted to go fast. I hope I didn't leave anyone's head spinning for talking too fast, but that is a brief overview of our major behavioral health related projects.
Thank you very much, Michelle. This is Mary again, everybody. And if anybody wants to ask a quick question now, we certainly could do that. I don't see any chat, but I'll pause for just a moment. And if anybody wants to unmute and ask Michelle something now, let's go ahead and do that. And if not, as I mentioned, when we send the survey out, you'll see that we have on the survey each of these 4 focus areas referenced, and we really would love your input on which of these you are of interest, where we could give you more information. Certainly, I'm sure the waiver will be of interest to some, but please let us know. Any immediate questions right now for Michelle? Let me pause for a minute.
This is Mary Maddox-Gonzalez from Redwood Community Health Coalition, and I had a question relative to the waiver, but also obviously impacts other areas. And that's in the work that you're doing. Are you looking at the potential for carving in alcohol and other drug services into managed care Medi-Cal plans to better integrate those services and the provision of them?
That's not something that we've looked at specifically, although we just started, so on the waiver, on the 1115 waiver work, we really just started those conversations with the state. So right now we are thinking through different incentive proposals. We have one we're working on, and again, I'm happy to share. All this information will be public after the 15th, so I'm happy to share it and to provide an update next call. One of the proposals that we are putting out there for public comment is to have a shared accountability structure through an incentive pool between DHCS, or DHCS actually would manage it, and then between the health plans and the county programs responsible for both specialty mental health services and then drug and alcohol treatment services. So I think there are different structures that would have to go into place for the mental health programs and then the alcohol and other drug treatment programs. So that's something we're going to be getting more feedback on. In terms of carving it in, that's something that has been put out on the table at this point.
The perspective of our health centers, it would be very helpful because it's an even greater issue than trying to coordinate the mental health services. And I just think it certainly we would find it very useful. Although I know it's a politically very sensitive issue, but from the perspective of kind of making it more person-centered and better integration, I think it is quite helpful.
And I guess a question would be then maybe, which we can think about offline and come back in January and have more conversation, would be is how does this then intersect with the substance abuse, the drug waiver, that's Medi-Cal waiver that's going forward?
Thanks, Mary. I was actually just going to mention that there is, a proposed amendment to the current 1115 right now that I believe was just submitted to CMS a couple weeks ago, I think. There is now I am not going to pretend to be an expert on that, so I'm not going to really provide a lot of detail on that. But what I can do is I have a link to the latest waiver amendment submission is on the website. I'm happy to share that if people haven't seen it. yet, but I believe that that has some more opportunities for counties to better align with physical care. Again, I'm not sure about the extent to which, of integration that would result from that, but I do think that there are part of the waiver would aim to improve that. But the other thing to note too is we've also been talking a lot about proposals. This is more from a mental health perspective, but incentive structures to reward increasing levels of coordination and co-location between, primary care offices and behavioral health offices, whether or not the middle home, so to speak, is one or the other. So thinking about how to incorporate substance treatment into that is something, too, I can bring back to the work group.
That would be really helpful.
Michelle, this is Kathleen Clan from Alameda County. I was wondering if you have any advice for us about participating in the waiver process. I'm worried, and I'm sure others are, that it'll end up getting driven more by where the dollars go, and that the scholarship that we have around best practices will end up being lost. So just translating that into how do we actually have input into that process. We can see that the work groups have been chosen. Mechanically, how do we get kind of our voices, our ideas at that table?
So there are several work groups. The only one I can speak to directly is the one on the provider incentives. There are many, though, and you might have interest in activities for some of them, for one of them. So what I would say is, what I can do is provide you, if you haven't seen the website with all the information about the different work groups, there are all of the meetings that the stakeholder work groups are holding are public, or at least I believe they are, and there are opportunities for public comment. Now, of course, I know that you'd have to be there to give public comment, but there are also websites and electronic mailboxes where you can leave comments. And, we're also happy to, all of the documents, the draft proposals that we're seeking feedback on the slides, those will all be posted, and I can make sure I can send everything to Mary if that's easiest, to make sure that you have the most up-to-date materials after the meeting, after the 15th. So if you have any feedback that you'd like to send to us at CHCS on any of the materials that we present on the 15th for consideration, for the next meeting, which I believe is on January 23rd, at least for my group, we're happy to accommodate that the best that we can. And also, we have I'm working with a woman who is facilitating all of the different work groups. So if you'd like me to work with her to try to get some more concise information about exactly how people can participate outside of the work groups through public comment, I'm happy to send out a brief summary of that as well. That might actually be helpful.
Is that Bobby Wunsch? Is that who you're working with?
It is.
Yeah, okay. So two things. This is one. Rachel just put in the chat a link for those of you who can see it to the labor work groups that Michelle's referencing, but we will set out actually after the call as well to everybody. And I want to emphasize that one of the reasons we invited Michelle today and that we're having them back in January is because these calls are strategically positioned around when they are leading some of these work groups. So we really do encourage you all to, work with us in the interim as well and help us craft the agenda for this call in January with Michelle and Allison to really form your input into them on these issues that are of concern and interest, obviously, to your day-to-day work.
Thank you. And I can say, too, to whatever extent I am able, if you have, after all these things are posted, and if any of you have individual questions about, where they're going and what they're planning, to the extent that I can provide information, not being at the state myself, I'm more than happy to walk you through anything. So offline, if that's helpful.
Okay, Rachel, did you want to add anything? I know you've been tracking this too, so before we move to Elizabeth and the presentations.
I just want to piggyback on Kathleen and Mary's comments, which is, this process is, these work groups are open to, there's public call-in lines for all of them. And, I think behavioral health is coming up every single one in one way, shape, or form. And so mentioned, the SEO provider thing, which I think you're going to be really interested to see what's on the table there. And once those resources are posted publicly on Monday, and to weigh in on that, as well as mentioned DISRIP, it's in there. Workforce, another area where I know behavioral health is coming up. So I think there's a lot of opportunity. Housing, there's a little discussion around supportive housing. So there's really a lot of opportunity for you to weigh in, and I think it'd be great if we can even use our email kind of listserv to dialogue, between now and the next time we talk. I think that's useful too. Maybe there are folks on this call that share a number of positions on some of this stuff.
Well, thank you very much. I think, this will be really helpful to have this ongoing conversation, and especially in terms of the waiver, which is going to be submitted, targeted, I know, for February. So things are going to be moving quickly. So we look forward to having this again next month in more detail. And again, just, pepper us with any thoughts or emails that you have on this as the learning community. We'll be happy to keep that information flowing back and forth. I want to turn it over now to Elizabeth and let her talk a little bit about the presentations for this afternoon, and how we ended up here, and then introduce the grantees who so graciously came forward to be the first to present in a little bit more detail some stuff going on in their partnerships. So, Elizabeth.
Great, thank you, Mary. Thank you so much, Michelle. That was a great overview, and you can hear, as we all would expect, how much interest there's in everything that CS is doing. And I just wanted to take a minute and put in a plug for the SurveyMonkey that you'll all receive immediately following the webinar. It's super short. It'll just take a few minutes. And the reason I just want to mention it now is there is a question about Michelle's overview of the CHCS initiatives that's shared, and really asking if you all can weigh in on which particular ones you would really like to hear more about and drill down on. So if you can answer that, that will also help us shape how we act with CHCS and what they do on January 21st and what we do in the meantime. So if you can answer that, it'd be really helpful. So I really appreciate everyone who did answer the SurveyMonkey after our last webinar at the first week of November, because that's part of how we got here, which was many of you indicated interest in the other partnerships, and sometimes generally, sometimes really specifically on their projects and goals during this grant period and what they were working on. And in some cases, things that they had, many of your partnerships have been working on these things for a long time, and during this grant period, it's really enhancement and continued work on much bigger initiatives and goals. And so we asked three of the partnerships to pick something in their particular goals for this period to drill down on a little bit and talk about more specifically. We asked them to pick something in one of three areas, and those three areas were information sharing, and not on the broadest level. It could be data sharing for population management or clinical data sharing for specific patients, everything in between, or in the area of strengthening relationships in the community between partners and providers, or in the area of complex care for patients. So for the areas, we ask these partnerships to pick one, and then we just ask them to talk about something that was very compelling and interesting that they're working on. So it didn't have to be shiny star that was all fixed and great, although it certainly could be. It could be something that was particularly challenging, or that they're just right in the midst of, just to talk in more detail about that. So we have Shasta County right here in front of us who's going to present first, and we have San Bernardino County, their partners, and also San Diego. So I really appreciate these three partnerships for being willing to do this. And we're, of course, going to hear from the rest of you at another time farther down the road. But thank you so much to you three for being willing to to do this first today. And with that, I'll turn it over to Shasta.
This is Lynn Dora. I'm long familiar with some of you, and I'm gonna start the presentation, and then Melanie Ridley will chime in as well, and Doreen Bradshaw and Marta McKenzie are also on the call. So I'm hoping that if we forget, if Melanie and I fail to say something, that you guys will chime in. Here we go. Next slide. In some ways, the greatest strength of our project is the collaborative itself. So I want to talk a little bit in detail about that. Shasta County is somewhat unique in that we're big enough to matter, but we're also still really small. And we have an urban hub in Redding, although the vast majority of the county is very rural. And long ago, in the 2006, SHARC, the Shasta Health Assessment and Redesign Collaborative, out of an earlier effort called SHARC, which actually focused specifically on mental health. So SHARC is focused more broadly than that. I think that one of the things you can see on the slide, the membership, it's very comprehensive. It's a meeting that everybody takes seriously. We meet once a month at 7 o'clock in the morning in Redding. So for those of us who live an hour and more away, it's kind of a big commitment to get to Redding at 7 o'clock in the morning. But we do, and I think that the work that we've done in the last several years has really built a particularly strong relationship with our county. So we see ourselves in any kind of an adversarial relationship with the county, and on the contrary, work very closely with them. Okay, next slide, I guess. So big win was to succeed in getting the COAST model approved for the far northern counties in the form of partnership health plan. Worked very hard on that. We succeeded, and then we did a strategic planning process, which resulted in 3 priorities: increasing access to health services, both primary and specialty care, promoting an integration of behavioral health into primary care, and developing and supporting a health information exchange. So obviously the subcommittee that includes the 4 of us on the call are working on number 2, the integration of behavioral health into primary care. The needs assessment activities that have been conducted today are a document review of all the data that already exists, comprehensive clinic interviews with the 4 FQHCs in the county, and a comprehensive catalog of community support. I think it's important to mention that in the rural parts of the county, in all of the communities where there is an FQHC, the FQHC is really the only resource base in those.
Recording started.
Yeah, I think you're all right. For some reason, the recording restarted, I guess.
Mm-hmm. Okay.
Sorry. Go ahead. I'm sorry.
So this is really FQHC focused because in the rural parts of the county, which is the vast majority of the geography, there are no other resources. So we're kitchen sink full of all kinds of different delivery services. So that's the reason that we are really focusing on the FQHC component of all of this. Melanie, I'll let you talk about data.
Thank you. I'm Melanie Ridley, and I'm a consultant that works with the Health Alliance of Northern California, which is the clinic consortium engine, and also serves as the lead agency supporting the collaborative. And our first objectives and activities under this project was to really get a better understanding of behavioral health integration looks like currently in the delivery system, and then what are the needs and capacities. So if you can go to the next slide. We've started to gather mostly publicly available data to start getting a sense of where we're at. So Shasta County, the total population is a little over 181,000 people, and using primarily the state's behavioral health needs assessment report that was part of the 1115 waiver planning process, we had to get, try to put some numbers to what is an estimated number of individuals that are in need of either specialty mental health services, mental health services within more of a primary care delivery system, that mild to moderate population, and then also substance abuse treatment services. And we've been pulling data from different sources, looking at trying to get utilization, who's being served where, trying to understand those pathways of care, how referrals are working, how people sort of make contact with the healthcare delivery system, whether it's county or through the FQHCs or through private primary care providers, emergency departments, or the hospitals in other ways. We're trying to kind of bring all of that information together. And, so I just included a few of the kind of key statistics that we've been compiling from the various data sources. And it's really helping us to build this picture of what's the system looking like. And then really, as Lynn mentioned, to understand what's happening within the health center settings, in the private primary care setting. Doreen Bradshaw and Marta McKenzie, both part of this project, went on site and interviewed health center CEOs, primary care providers, and behavioral health care providers, and really sat down for a pretty comprehensive interview process to understand how mental health is currently integrated into primary care. And within 4 FQHCs, there is, quite a bit of integration of mental health care in primary care service delivery system. Understanding how telemedicine is used for psychiatry consultation and access, how care coordination is looking within the health centers, are substance abuse services integrated, and to what degree, and then if the health centers are serving populations with an SMI diagnosis, and that looks like. And then they also sat down with a private primary care provider that does serve the Medi-Cal population to understand from a private medical office perspective, how a sole practitioner is trying to accommodate the needs of their patients who have mental health or substance abuse needs. So it's really helping to develop this really clear picture of where care is being delivered to who, and then also identifying a few of the gaps. And so right now the subcommittee, the Behavioral Health Committee, is working to take a look at that, look at where those gaps are, where those needs are, and then identify some strategies to test to increase access to care. So I'll turn it back over to Lynn to talk a little bit more about what that's looking like.
Okay, so the last slide. The options that we're looking at right now are the co-location of substance abuse providers into the SQHCs. There are 3 existing Medi-Cal providers in the county. At this point in time, all of the services that are available are only available in Redding or slightly north and south on the I-5 corridor. So for patients in the rural parts of the county, that's a very significant scoot, particularly for substance abuse services, which ideally would be offered more than once a week. One model, co-location, to see if we can entice anybody to come out to us. Behavioral health care manager, this is the alternative that my organization, Hill Country, is seriously considering. We have a role internally called the Behavioral Health Care Coordinator. We're about to add a second one, trying to decide if we should just do it, just hire somebody with substance abuse treatment experience, not ever expect to get paid for it, and just integrate it into our primary care teams. And then the third clear priority from talking to everybody is to increase training to providers and support staff, the team within the team-based model, to increase our capacity to address both mental health and substance abuse services. Barriers that are that everybody on the phone is familiar with, I know, and they play out a little differently, I think, in each county and each community. Us up here, we actually also have a concurrent project that was belatedly funded by the Federal Office of Rural Health Policy. So we looked at the proposal, it didn't get funded, and we kind of forgot about it and focused on this one, and then it ended up getting funded later, which is the development of a rural network to address many of these same issues. So for the rural clinics, a huge issue is transportation, as it is in every rural conversation that ever comes up. And then, of course, there are the structural barriers about how does one bill for it, and how do we build this into an FQHC model, given the reimbursement restrictions and what appear to be there's a flux right now at the state level in terms of substance abuse treatment and how that funding stream moves forward. We had a conversation locally talking about bumping it up to the next level of statewide policy. We have had a local conversation about the possibility of an 1115 pilot that would carve in substance abuse into managed care. The folks in the room, meaning the county people, feel like the way the substance abuse waiver has been written, that possibility is contained within it the way it's been written. So there's no movement on that, but a discussion has been started. And one of the things I would say is emerging as we're getting deeper into this relationship building and learning more about each other's organizations is, and I think this probably speaks to some of what Marty's presentations in San Diego were at the conference were about. There's this fuzzy role that is emerging, and for the 4 FQHCs in Shasta County, it's playing out differently in each FQHC. We call that role a behavioral health care coordinator. Somebody else calls it a case manager. But what does it appear that perhaps the development of that role in kind of a coherent fashion where sharing of training and resources can happen is a building block towards improved integration of substance abuse treatment. So I think that's about it, what we've got.
Much. Thank you. Really appreciate that. And we'd like to take a few minutes for questions for Hank before we move on to San Bernardino. I don't know if anybody had chatted in, Erica, or if anybody has questions.
This is Kathleen Clannon from Alameda County. We had a couple. One was we wondered if you would just say a little bit more about Hank, what kind of organization it is. We weren't perfectly clear if it's your local plan or it's a provider. Anyway, a little bit about that. And we were curious, the last bullet on the second slide showed, I think it was 6% of the referrals to outpatient AOD came from primary care. We'd really love to know what that is on our system, to be able to track it as an outcome. And we wondered if you could say more about where those numbers came from.
Melanie, can you answer or Doreen? Doreen, are you still on the phone?
This is Melanie, and I'm happy to answer the question about Hank. So the Health Alliance of Northern California is the network in the region. So the FQHCs, rural health clinics, are members of this regional association, similar to the Alameda Health Consortium I think what area. The Health Alliance has been very much engaged and served as a leader in terms of some of the health system redesign efforts over the years, and has held this role of serving as a facilitator for the collaborative for the broader county. In terms of the question on the referrals, that actually came from a report that was produced. It's a little bit outdated now. I believe it was from 2010, but this was the report produced by the Center for Applied Research Solutions on behalf of the county around indicators of alcohol and other drug consequences for California counties. So I'm happy to share this report with you. And
this is Kathleen again. I just want to make sure we're talking about the same piece of data, because on the slide it says it's fiscal year 13-14, and it says the source is county HHS data. That was the one that we were curious about and wondered kind of what's the numerator, what's the denominator. We were curious about what other 94% of referrals came from. So you were just making me worried that maybe we were talking about two different things.
Okay.
No, this is Lynn. I'm not putting my hands on that data as we speak, but it's my recollection of it, Melanie, is that it came from the county, and the other 94% is some of it is self-referral. A lot of it is the legal system, ordered referral. I think that that piece of information, whether it's 2010 or 2013, I think is available for all counties, and we can do that out. It came originally from Shasta County Drug and Alcohol.
You are correct. And Kathleen, I'm happy to follow up with you afterwards in terms of the information, getting you numerators and denominators and how we came to that. So I'm happy to answer that question offline.
That'd be, thanks.
If there's one question, we could probably take another question before we move on.
Michelle, I have a question. I'm curious, just looking at the CDSMI population and then what county, the purpose of that population served by the county, and then the next bullet around ED site contact. What's the conversation you're having around that piece of, kind of intersect of those pieces of data?
Impact on the emergency rooms, is that what you mean?
I guess I would characterize it as looking at the numbers kind of one of unmet need, or do you guys sense that there's 7,332 estimated with an SED-SMI diagnosis, and you have below that the county's serving like less than half of those folks?
Mm-hmm.
Do you know how do you think about those figures and next figure as well? So is that, with that comparison, is that a signal of need, or are those folks being served somewhere other than county? How do you look at that data?
The first column there is serious mental illness. The middle one is the broader definition that includes mild to moderate. There's absolutely a shortage of services for people with serious mental illness. FQHC is up here, as I think is true in many, many places. We actually serve more SMI folks than this sort of want to acknowledge that we do. The need is enormous. Hill Country is located an hour from Redding, and we have, daily we have families and individuals with serious mental illness somehow getting themselves out here because we have some reputation for expertise with helping that population. So lots and lots of unserved people.
This is Dean Germano, and my program, my health center is based in Reading, and just by virtue of my organization having a couple of psychiatrists, it's almost been a magnet for a lot of that differential as well. And so for those, at least in this area here, I suspect I have as many as the county does in terms of patients, which really wasn't how we initially designed our program, but it has, just because of the shortages Lynn identified, has resulted. And I did meet with the county the other day, and we were talking about this population, and we wanted to refer to our SMI population as SMI. And I said, what's the S for? Stable, seriously mentally ill. And I think it was just, a concern that they didn't want to, they were concerned that the state, it is a responsibility, but they're so under-resourced, both in terms of dollars and in professional manpower, that, that's where they landed. So we called our SMI population more on the stable side, and our goal, of course, is not let it spin out of control. But it has been tough. I mean, our HPSA scores in this region for mental health, I don't know, Lynn, it's up there 223.
I think it's 22. Yeah.
Yeah. So I mean, I think it's like next to the worst you can in the United States as far as psychiatric support services, at least on the psychiatry level. But that's our reality up here. It's really, there's some big holes in the health centers, Lynn's and mine and others, that are doing our best to wrap around the patients as best we can, but it is really tough sledding.
Thank you for speaking to that. I think we probably need to move on now. I appreciate you speaking about, I think, an issue that obviously, that all the rural areas will relate to, and I think many of our urban partners will relate to as well. So, and I appreciate the interest and, of course, to be continued in terms of our conversation between all of us in the learning community. We're on to San Bernardino, so I'll go ahead and hand it off.
Everyone, my name is Liz, and I'm with the Community Clinic Association of San Bernardino County. I wanted to give you all a brief overview of our partnership prior to going further into depth into the presentation. So our partnership name is the Integrated Safety Net Partnership, ISNP for short, and we're a project under the Community Clinic Association of San Bernardino County. And we're very fortunate to have a pretty large, diverse group of partners, which include our two county agencies, the Department of Public Health and the Department of Behavioral Health, as well as our community health centers and clinics that are part of our association, a few mental health and substance abuse providers that are part of an organization called the Association of Community-Based Organizations, also known as ACBO, as well as our county managed care plan, IHP, and our supporters in expanded use of technology, including the Inland Empire Health Exchange and the California Telehealth Network. So as a partnership, our overarching goal is to develop a collective vision of advancing integrated care in our county and really strengthening the capacity of our county's community health centers and behavioral health providers to do so. And then another of our goals is to increase the use of technology, including health information exchange and telemedicine, to expand access to care in our geographically dispersed county. And the last goal, which is what I want to share a little bit more about, is our goal of replicating and supporting some of the successful work that's being done amongst our ISNP partners. So we're very lucky to have Megan Ellis from the Department of Public Health be involved in our ISNP partnership, and I asked if she could present a little bit more information about the Department of Public Health's Collaborative Integrated Psychiatry Program, which is one of the programs that we would like to rate in our county and really support. So I believe Megan is on the line, so I'll hand it over to Megan.
Good afternoon, everyone. As Liz said, my name is Megan Ellis. I'm with the Department of Public Health in San Bernardino County, I'm the Chief of Community Health Services, and I also serve as the Health Center Director for our FQHCs. We have 8 clinics in the Public Health Department, and 4 of those provide primary care services as well as historical, categorically funded public health services. We've been in primary care since 2012, and we decided to expand our FQHCs. We had been at 1 prior to 2012. In 2012, we were able to pull another clinic into our scope, and then that is the clinic that I'll be talking about today. It's in the high desert area of our county. It serves the most areas that have been identified in the high desert. The score in that area is about a 14 to 18, depending on where you are in that region. And historically been extremely underserved. We're only health centers up there initially, and then since 2012, a couple of us have joined us. A large populated area. It's desert, but there is a lot of population there. So I wanted to talk with you about our behavioral health integration and what it is that we have been doing. After we integrated primary care, and then when the waiver went into effect in the low-income health plan, the bridge to reform, we started to see patients in the clinic that were behavioral health patients but were considered to be stable, whether they were seriously mentally ill or not, and they were being sent to us for to be able to do medication monitoring and oversight. So there soon came an issue among our providers of not being able to understand the process. They hadn't historically dealt with these patients. They weren't clear about psychiatric medications. There were a lot of gaps to fill. So patients started to go between us and behavioral health. The behavioral health sent them to us. You know, you're not sick enough for us to see you. Go to your primary care provider. The primary care provider was like, I know how to treat this. I'm sending you back to behavioral health. So oftentimes the patient would go back and forth before we realized it was a real big issue for a lot of our population. Started to meet with behavioral health, which is our the county behavioral health department is the managed care organization in this county. So we met with them and we started to talk about these patients that were bouncing back and forth and how could we provide better service to them, and that's where the integration idea was born. There's been some co-location done in the county where they are embedded in a building that also serves primary care, but in the instance of this in this facility, we actually have brought in the psychiatrist into our setting, and we are looking for ways to be able to integrate so that there is looking at the patient-centered medical home model where there's one provider who's directing the care of the patient and pulling in resources to be able to manage that patient. So we also simultaneously applied for another grant, a behavioral health integration grant through HRSA, and we're able to get that grant, and that grant gives us $250,000 per year for 2 years for us to be able to expand what we need to do, which was to bring in this provider, build a team related to psychiatry in the clinic so that when the provider is in the room with the patient is identified as having an issue, the provider can go get the mental health provider who can come into the room. We're using mid-level providers at our clinics in addition to our physicians. So oftentimes an NP or a PA who's the first one to identify this through a multitude of screening tools that we've put in place. And the person goes and gets an MFT and does the initial psychiatric screening. Once a week for 8 hours, we have a psychiatrist that comes in and we do a grand rounds type of interaction where the providers present their patients, and those that are very complex, the psychiatrist will see the patient if he needs to, or give them oversight and direction. Really depends on what's going on with each individual patient, how that patient gets managed. But we don't want to patients to see the psychiatrist because it would undermine our patient-centered medical home model, and then it would also take up a huge amount of his time. We had seen that in the research that we did, that type of a model, very quickly the physician gets booked and you're back to where you were. So with the grant monies, what we decided to do was put a change of scope into HRSA so that we were able to provide mental health services at the clinic that included behavioral health and substance abuse and use, and that we would hire mid-level providers, which we consider to be the MFT or the LCSW, and that we would build this team and embed them within the clinic so that there was real-time interaction with the patient. So we have been able to do that. We just got the grant, and we've hired the MFT, and we've started that process of the patient interaction with the MFT from the psychiatric standpoint. And the psychiatrist's goal is to train that individual to about the level of a psychiatric resident so that that person can utilizing tools that the psychiatrist is developing, give him those tools, and then he collects all the baseline data for the physician, and the psychiatrist reviews that, and then gives recommendations for treatment, makes a decision to see the patient, or whatever the appropriate thing would be. We have to have 2 to 3 MFTs see patients, which would really assist us to be able to meet the gap of the patient right now. And we also want to look at the ability to be able to replicate the model. So we've just started with the mid-level. We are identifying our metrics for quality improvement to see what it is that we're going to be seeing with these patients over time so that we're able to demonstrate that this is a good model for us to utilize, hopefully to publish at the end about it. Hopefully it will become it's definitely a promising model at this point. Whether it will become a best practice or not remains to be seen. I just don't think we have any data about that yet. Locally, we're working with our Department of Behavioral Health to even expand the integration further in the sense that we have a clinic for behavioral health located not that far from the FQHC, where they do see severely mental ill and unstable mental ill patients. And we would like to put screen tools in place at that facility for them to be able to screen for the physical health side, because that's not happening. So our integrated group continues to meet to discuss opportunities that we may have to be able to do that piece of the work. And then also, because we have a capacity building grant at that same health center, we're putting in a state-of-the-art conferencing room for us to be able to open it up to the community at some point and bring those primary care providers in the community that face these same issues and don't have the ability to be able to have some of the resources that we do, so that we have like a lunch webinar where they could access the psychiatrist and talk about cases, and a lot of learning could go on during that period of time. So, we're really excited about the project. There's a lot of opportunity for us to be able to really impact in a positive way the quality of care that these individuals are receiving, and we're really hopeful that the outcomes and metrics that we're going to be looking at will demonstrate that over time. And I'd say go to the next slide. I'm sorry, I was talking. That concludes my presentation. I'm so sorry. I forgot all about the slides.
That's okay. It happens.
I'm so sorry.
It's better listening to you. You've had a lot. So thank you so much. We have time for sure for one question. I don't know if there's any chatted in or if somebody has a question. No? If there's no questions right now, why don't we go on to San Diego, and then certainly at the end of San Diego, we'll have questions for San Diego, and then if people have thought of questions for San Bernardino, we can also do that. So I'll go ahead and turn it over to San Diego.
Thank you. This is Marty Edelman here at the Council of Community Clinics in San Diego. Let's go to the next slide if we can. So it's good to be back with you, and I want to thank Rachel for the shout-out. It's good to know that you were paying close attention to everything we said yesterday, but I also feel you covered about a third of what I wanted to say today.
I didn't mean to steal your thunder, Marty.
Okay, I'm just kidding. So when I talked a bit about our key objective, which is improving cross-system integration, and the two pilots that we felt were kind of at the heart of that whole process. One collaborative treatment plan and the other one focused on transitioning individuals with serious mental illness. So today I want to focus in greater detail on the second one, the transitioning individuals with serious mental illness to primary care, and really want to make it clear that there's a couple reasons, or a few reasons why we would want to do that. One would be that we feel graduating people back into the community wherever possible is going to help them feel more normal and reduce the stigma around having a serious mental illness. Obviously, also, it's going to open up a slot in the specialty mental health system for somebody else who may have more severe need. And, finally, by ensuring access to primary care for those with serious mental illness, we're able to, hopefully do what we can to reduce the morbidity disparity. But before I get into the sort of heart of the matter around that particular pilot, I want to back up a bit and reiterate some of what Rachel said, because I think it's really important for people to have an idea how we got here. We didn't and probably wouldn't have been able to just call up a special mental health program, some of our FQHCs, and pitch the idea of this pilot and expect it to work without these organizations having some existing relationships and a history of success working together. Next slide, please. So just a bit about our history. We started with down the integration pathway in around 2007, and we started with what would be considered traditional integration by dropping a mental health person in a primary care setting at some of our FQHC sites. Next slide, please. And after a couple of years, around early 2010, we got some SAMHSA funding to do what I'm referring to here as reverse integration. We put nurse managers into specialty mental health settings. And nurse care managers were outstationed from local FQHCs, so that right there we began the process of developing relationships between specialty mental health programs and some of our FQHCs. Next slide, please. Skip that one. Thanks. And we started thinking kind of in a grander sense about integration. In the mid-2011, we started forming learning communities made up of regional triads of of special mental health providers, primary care providers, and AOD providers. And I want to mention at this point that none of this would have been possible without the support and direction from our county leadership, who have been valuable partners in the brainstorming process and in the funding of many of these activities. Next slide, please. So that leads us to kind of where we are. And in my view, the two pilots that we're talking about are really kind of a logical next step in the relationships between our triad members. And I don't think it needs to take 7 years to get to where we are now, but I do think for me to be able to call up the leadership of these 4 different programs that are on the slide now and ask to have a meeting and have everybody show up and have everybody agree at the very first meeting they're willing to participate in this Blue Shield project was made easy by the fact that we had all these existing relationships and existing experience doing this work. So at this point, I'd kind of dig in more to the pilot involving transitioning individuals with serious mental illness to primary care. The slide identifies the partners for this particular pilot. We have one specialty mental health program, UCSD Gifford, paired with 3 of our community health centers. And the goal is to pilot a process to ensure individuals with serious mental illness who graduate out of the specialty mental health program are successfully transitioned to one of the participating community health centers for both their behavioral health and primary care services. So the specialty mental health provider has identified a significant number of clients who are ready to graduate from specialty mental health, already patients at one of these 3 clinics. That's kind of the first step in the process. And our specific intervention that we're going to be using to see if we can affect the ability to get these people to transition is our staff from the community health centers will be going to the specialty mental health program to provide 1 to 2 transition visits prior to the care at the community health center itself. And we believe or hope that this will provide a graduate who's moving from specialty to mental health to one of the community health centers an opportunity to get to know someone from the community health center before they transition over. It would also allow the community health center staff person a chance to kind of prepare the individual for what it's like at the community health center, because it may be a bit different than the specialty mental health program. And finally, it will afford the community health center staff person a chance to confirm that this particular person seems appropriate for their community health center. So again, our pilot is there to kind of test whether the intervention of having these transition visits will include individuals' willingness to transition and overall success of transitioning people from specialty mental health to primary care. Next slide, please. Okay, so kind of step 1 will be that our UCSD Gifford staff will identify the individuals who are ready to transition to primary care for medical care and ongoing behavioral health care, and who have reported one of the aforementioned clinics to be their primary care clinic. At that point, the designated UCSD staff will meet with a client to discuss the possibility of graduating to primary care for ongoing treatment and obtain the necessary consent to contact the appropriate community health center. And we want to convey the process of transitioning from primary care or transitioning to primary care, I should say, as a positive event. At the same time, we felt it was necessary to use some kind of a standardized process so that we could tell people exactly what we did when, in fact, we got awesome results at the end. So we've developed some talking points that we've asked the Gifford staff to use as part of the conversation with the client regarding the transition to primary care. Next slide, please. So these are the talking points I was referring to, and I won't read them to you because they're there on the slide. But we just want to make sure that people are viewing the idea of transitioning as a positive thing, so we're referring to it as a graduation. And we want to make sure they understand the opportunities that this move brings to them. So, you know, it's ensuring that they're going to get primary care. They'll now be able to get all their services in one place. At the same time, we want to let them know they're not being abandoned by Gifford Clinic. So we want to let them know that Gifford will be monitoring their success. And if at any point in the process they need to go back to Gifford because, say, they've decompensated or, you know, for some other reason, Gifford Clinic will still be there for them. Next slide, please. So the eligibility criteria that we've developed, and this is Mary was asking me briefly about in the last webinar. So I've listed that criteria again, and I won't read them to you because they're on the slide. I do want to say that at this point, I feel like these particular criteria are as much guidelines as they are rules at this point, because in our last meeting we had just last week, we were talking about, well, what if somebody meets, you know, most of these but not all of these, and that there is some negotiation around some of these items. I know, for example, that there'd be much negotiation around whether or not somebody's going to provide an IM shot, but you know, if somebody's had a stable medication regime for, you know, 6 months, with the exception of the addition of or slight tweak in one of the medications at some point, you know, these things are, like I said, more guidelines and rules. Next slide, please. So a little bit about communication. Once the Gifford staff has identified the individual who's ready to transition and obtained appropriate consent, the Gifford staff initiate contact with a designated staff person at a particular participating community health center to schedule the first transition visit. And at that time, Gifford staff would also fax over the behavioral health assessment and the most recent psychiatrist's notes to the community health center. The dedicated staff at each community health center are blocking out time each week to meet with transitioning clients at UCSD Gifford. And Gifford has agreed so that they don't waste that community health center's time, that if there's not going to be a client/patient ready to set particular blocked off time, they would let them know with at least 4 days notice so they can reschedule that time back at the community health center if necessary. Also, the staff at the community health centers have to regularly communicate with the Gifford staff to monitor any residual risk, resistance the client might have about transitioning, and if there is some, to let the Gifford staff know about that. To also let the Gifford staff know the date of the client's first appointment at the community health center, and then let the Gifford staff know if the client actually attended his or her first appointment at the community health center. Next slide, please. So communication between the designated community health center staff person and the designated UCSD Gifford staff person begins the scheduling of that first transition visit. And as this slide kind of shows, will continue until the patient has successfully attended his or her second medication management appointment at the community health center. And at that point, that's what we're considering a successful transition. The other thing I wanted to mention here around communication is that the UCSD Gifford psychiatrists have agreed to remain available for consultation with providers at the community health centers who are taking over responsibility for the medication management at the community health centers if requested. So hopefully that'll make our primary care providers at the community health centers feel more comfortable about taking these clients. Next slide, please. So the Gifford staff are being asked to, within 1 week of the client's first scheduled appointment at the community health center, contact the person or the person to evaluate how that appointment went. Next slide, please. We've developed this diagram, and I apologize for you not being able to see it really well. I can send it out to everybody in a different version. It will show up better. But this is, again, our effort to kind of standardize the process so that we know we're kind of doing the same thing every time, and we know when we measure to see if it worked, we know exactly what we did. So in an effort to standardize the process, we've created this diagram which maps out the conversation between the UCSD Gifford person and the client following that first appointment. Next slide, please. It says within a week of the first appointment at the community center, I'm sorry, this is just a repeat. Skip that one. The questions that are actually in the evaluation, they're in that diagram, but this is in another form. So this is the form we're going to use to actually track the questions that we're asking the client, and so we're going to be tracking this data and following to see how well the process goes with these particular clients. And we're also developing all of these things into a protocol, which we would happily share with everyone if anybody feels it would be helpful to have that. So that's kind of what we're doing in as great a detail as I can provide right now. And I'm sorry if my phone's beeping. Somebody's trying to call in, which is really strange. But that's really kind of the details around everything that we're doing related to that particular piece of the project. So that kind of ends what I have to say. So I'm happy to entertain any questions or comments at this point.
Thanks so much. Thank you so much, Marty. That level of specificity and even the tools that you're using is really helpful. So thank you for doing that. And so it's 23 right now, and we want just at least a couple minutes just to wrap up at the very end. But if people have questions for me or for Liz for San Bernardino, please feel free to ask.
Hi, this is Aaron Chapman. I'm in Alameda County. Marty, thank you very much for the presentation. Question that we had here was, how have you been successful in San Diego in terms of creating a culture within your community health centers to accept previously SMI clients, particularly when they may be on antipsychotic medication or when what the stability might be a complex regimen will now be continued within a primary care home?
a great question, because you're really getting to probably the most challenging piece of the whole puzzle there. And my answer, part of my answer is going to be that we really started with the lowest hanging fruit. We really tried to find the clients who we felt, the patients who we felt would be the easiest for our FQHCs to accept, knowing once we kind of got our foot in the door, it might be easier to move to the complex people. We also started with organizations who were more willing. We have a couple of organizations in particular who it's really part of their mission. The whole behavioral piece is built right into the kind of fabric of those organizations. So we're sort of hoping that by choosing the organizations that are more in the forefront and clients that are easier, we can show the success, and we have actually shown the success of this, and that other people will be less reticent. And so I think we're really worked for us to this point. Also there's just tremendous support in the whole community. The county is a big part of that overall support around this whole idea. So it's kind of like that whole notion is in the air, and if you're the person who disagrees, you're kind of out there by yourself. So, I mean, there's a number of forces kind of working with us. I don't know if you have other thoughts, Nicole. Anybody else here?
No, I mean, I think taken us 7 years to get to this point, first developing integration within primary care, then by doing the SAMHSA PBHI model, working with our triads. It's taken us a long time to get to this point, but I do think, that being said, we're still working with the clinics and community mental health agencies that are the vanguards when it comes to integration.
Thank you for that. It's always a good reminder that it's a long process.
Yeah.
I appreciate you just mentioning how many years in you are, so thank you. Hopefully we would have time for one more question.
Don't be discouraged, anybody, because it takes 7 years to get to this point. But
Marty's going to allow us all to skip ahead. We can
circles back to the comment you opened with, Rachel, and that Marty also emphasized, Nicole, is the relationship building can't be underestimated in developing integration approaches.
It's so true. It sounds so trite, but it's so true. When you actually know the person you're calling at the other end and you've got a relationship with them, it just seems much more willing to, give something a shot if they got a relationship with that.
Well, it's also increased accountability. So I'm going to try a lot harder because I know Marty than if I'd see him on a piece of paper connected to a referral.
Mm-hmm. Right. Really important point, and that's why it's such an important component of any systems change theory or agenda, is to really work on that shared collective accountability phase. What are you doing?
All right, 1:28. Mary, do you want to close for us?
Again, I just want to thank everybody, for your excellent presentations and your participation, and encourage everybody one more time to fill out the Survey Monkey that you're going to be receiving shortly from Erica, because it's really based on your feedback that we're able to build the agenda for the next webinar. And, of course, we definitely want to take advantage of the expertise that Michelle and her colleagues and having all the work they're doing on the policy issues that are impacting your work for our next webinar as part of the agenda. So please give us your thoughts and feedback on that. A couple other quick announcements. First of all, we did send out a couple save the dates for you, and we're going to be sending out a more complete calendar because we've narrowed down, I think, the rest of the collective webinar calls, and then our in-person for our meetings from January through of 2015. So the next webinar is January 21st. That'll be a call, and then we've asked you all to hold the date of March 12th as the in-person convening, which will be in Sacramento. I know folks have questions about the logistics and how many partners, et cetera, and we're sorting through all that, and we'll get that to you very soon, but we just wanted everybody for right now to hold that on their calendar so that you have participation, all the grantees cohorts have some representation there, and we'll give you specifics on the logistics on that very shortly. But do hold that date for now. And then the other quick announcement I wanted to was that we'll be setting up a web page. It's going to be linked through the Blue Shield website, but it'll be a link that you can access that only grantees and partners of grantees for this project can link and access, where we'll be hosting all the, it'll be the repository of all the webinars, and we're building out the website, but resources, links to things, and that should launch also in January. Erica's going to take leadership for us on that, so you'll be hearing more about that, but definitely welcome your thoughts and inputs on the kinds of materials you'd like to see hosted there, so let us know about that. So the only other last comment is to just wish everybody a Happy New Year, Happy Holidays. I see Alameda had an important question. Where is Liz from? From San Bernardino. Liz, say where you're from real quick.
I actually just replied back to her. I'm with San Bernardino County with the Community Clinic Association.
Okay, good.
I have something just really quick kind of along those lines about that really important question. Is just to, again, thank Lynn and Melanie from Hank and Liz from San Bernardino and Marty from San Diego. Thank you so much for presenting on this webinar. And just to encourage everyone to, just some encouragement to reach out to the other partnerships about things you're interested in and would like to hear more about.
You have lots of expertise and experience around the state, so take advantage of it. And if you need our help, let us know. Happy to
Thank you. Yeah, thanks everybody so much.
Thank you. Happy holidays, everybody.
Okay.
Stay safe and warm and dry in California.
Okay.
Bye. It's ominous outside.
About you? I'm going to buy a ticket to Europe today. Maybe. Sorry. Yeah, sort of scary though. Yeah. I'm not going to see my friends for a while. Yeah. But you're only 15, right? Yeah. So I've heard it's like with high school, after high school, it's like you don't really see people anymore. Yeah, until you're old enough to come back for holidays and go to bars. And bars are, it's like